Welcome back to the Explainer series for Decode Healthcare with Harshal. Now, if you were with us for part 27, you know we completely unpacked the laws of laterality. Today, we've got a very specific mission as we continue to decode the ICD-10-CM official guidelines. We're zeroing in on section IB14. Honestly, this is kind of the holy grail for coders because we're looking at the rare, strictly regulated instances where you are legally allowed to step outside the attending doctor's progress notes and actually extract codes from other clinicians. So here's a provocative question for you. Think about this. If a wound care nurse meticulously details a patient's condition in the chart, can you, as a coder, legally extract diagnostic codes directly from that nurse's note? Well, to answer that, we kind of have to challenge the foundational knowledge of every coder and auditor out there.
Because to understand the exceptions, we first have to respect the absolute rule. The CMS FY 2026 official guidelines state it loud and clear. Code assignment is based on the documentation by the patient's provider. This is the absolute law of medical coding. But you know how it goes with complex regulatory systems. There are loopholes, legitimate, documented, legally binding loopholes.
All right, let's take a quick look at our roadmap for today's explainer. We'll start with the golden coding rule, move into the ancillary exceptions list, then the primary provider anchor, and we'll wrap things up with social determinants of health. Okay, section 1, the golden coding rule. Let's talk about who actually establishes the diagnosis. Before we can even look at who else is allowed to contribute to a medical code, we need to define exactly who holds the ultimate diagnostic power. In the context of these official guidelines, the term provider is strictly limited. It specifically means a physician or any qualified healthcare practitioner who is legally accountable for establishing the patient's diagnosis. This is the person whose signature carries the ultimate clinical and legal weight. Bottom line, if they don't say the patient has a disease, from a coding perspective, the patient doesn't have it. So let's move on to section 2, the ancillary exceptions list, or as I like to call it, the legal loopholes of section IB14. Section 1B14 outlines those rare instances where you can actually pull documentation from clinicians who are not the patient's primary provider. The guidelines explicitly allow you to use documentation from ancillary staff for these specific elements. Why? Well, because these are the clinicians tracking these metrics the closest. A registered dietitian is often the one calculating the exact body mass index, or BMI. A specialized wound care nurse is measuring the exact stage of a pressure ulcer or the depth of a non-pressure chronic ulcer. For these specific things, you can legally extract the BMI value or the ulcer stage directly from their notes. And it doesn't stop there. Let's look at emergency and trauma exceptions. You can pull the Glasgow Coma Scale directly from an EMT's field report. You can pull the NIH stroke scale from an ER nurse's assessment. You can even pull blood alcohol levels or the intent of a firearm injury from ancillary documentation. These are incredibly specific metrics that frontline staff record in the heat of the moment, so the guidelines give us a pass to use them. Which brings us to section 3, the primary provider anchor. This is the golden caveat for compliance, and you absolutely need to pay attention here. What we're talking about next is literally the #1 audit failure point in medical coding. We call it the golden caveat. If you don't fully grasp this, using those exceptions we just talked about is going to land your facility in serious trouble. The crucial point is this. While the specific detail, like a BMI number or an ulcer stage, can come from ancillary staff, the underlying condition itself must be explicitly diagnosed. Let's put this into perspective with an example. Say the dietitian clearly documents a BMI of 40. You cannot just assume the patient is obese and assign an obesity code. No way. The physician must explicitly write the word obesity in their diagnostic statement. Once the physician anchors that diagnosis of obesity, then and only then are you legally allowed to pull the BMI of 40 from the dietitian's note to complete your code set. It's a two-step process. And the exact same logic applies to wound care. A coder cannot just look at a nurse's note detailing a stage 3 pressure ulcer on the coccyx and generate an ulcer code if the physician's progress note completely omits mentioning that the patient even has a pressure ulcer. If the doctor doesn't diagnose it, it just doesn't exist for you as a coder, no matter how detailed that nurse's chart is. We see this all the time in trauma coding too. An EMT logs a severe Glasgow Coma Scale score. Now, that's a fantastic metric, But a scale is just a measurement tool. The actual diagnostic anchor, like whether that coma score is due to a traumatic brain injury or an alcohol-related disorder, must always come from the legally accountable provider. Now, you might be wondering, what happens when the notes conflict? What if the wound care nurse says it's a stage 4 ulcer, but the attending physician copies and pastes an old note saying it's stage 2? The guidelines are crystal clear on this. If there's conflicting medical record documentation, you must query the patient's provider for clarification. You absolutely cannot just guess or pick the most severe option. All right, let's jump to our final section, social determinants of health, focusing on risk adjustment and codes Z55 through Z65. Social determinants of health, or SDOH, is a rapidly growing area in healthcare data. These are the social problems, conditions, or risk factors that severely influence a patient's health trajectory. We're talking about major life factors like extreme poverty, housing instability, or a lack of access to clean water. Realistically, attending physicians rarely have the extra time during a busy visit to meticulously document food insecurity or literacy issues in their primary clinical notes. Because of that reality, the guidelines explicitly allow coders to lift these vital risk adjustment Z codes straight from ancillary assessments. For example, if a social worker or case manager details homelessness, you can code it. If a community health worker notes food insecurity, you can code it. Remarkably, you can even use patient self-reported documentation for these social determinants, provided that the form is actually signed off by and incorporated into the medical record by a clinician. Grabbing these Z codes instantly gives everyone a much clearer picture of the patient's actual clinical complexity. So I want to leave you with this critical question to evaluate your own facility's compliance. Are you actively checking the primary provider's anchor diagnosis before you code the nurse's metric? Bypassing the doctor's notes for specific details is a powerful tool for sure, but it is entirely dependent on that golden caveat. The physician has to establish the condition first. And that wraps up our deep dive into section IB14. Please make sure to hit the like button, subscribe to the channel, and share this explainer with your fellow healthcare professionals, coders, and auditors. This is a rule everyone literally needs to get right. And hey, make sure to join us next time for part 29, where we are going to tackle section IB15, syndromes. We'll learn the exact protocols for coding a complex, multi-symptom named syndrome when the codebook just doesn't give you a single direct answer. Trust me, you won't want to miss it.